Let's do it. Welcome to the Crisis Jam session. A great time for us to collaborate and work on things. And I'll tell you, it's interesting timing since I'm sitting here at the CIT International Conference right now. I pulled in John Snook with me, but a lot of our partners from around the country happen to be here. And it's fabulous to see them all working together on this very same thing. So look, if you're new to the jam session, and we have some new participants that we've been recruiting over the last couple of days here at the conference, it moves pretty fast. So we plan on jumping in, covering a fair amount of information. Often David Covington's emceeing this. He'll probably join us in 20 or 30 minutes, depending on how we can do with his internet connectivity. But for now, I'm going to start driving us forward. And if you are new, we encourage you to jump into the chat, introduce yourself to the group. And ideally, if you want to be part of our mailing distribution list and any updated invites, you would put your email information in there as well. So it's an exciting time. And those of you that are doing tracking time, we're about 11 months away from our July 16th, 2022 implementation. 11 months. And I actually looked at that a little further because I know there's detail-oriented people in here. That does include you, Preston. And so it's 47 weeks. And those that like to dive deeper, like John Snook here, and really look at the detail, it's 331 days. For those of you that know it's 7,932 hours, you should take a couple of days off. Breathe a little bit, and we'll work through this together over time. But that's where we are right now. So welcome to the jam session. Again, please use the chat anywhere to jump in, and we'll be able to communicate as we learn together. So Karen, can we go to the next slide, please? I'm really excited about our featured presentation. So in the second half of the hour here, we are going to have a featured discussion from Gainor. And she has this fantastic title as the Executive Director with the National Association of State Emergency Medical Services Officials, very close to Brian's NASBID group in length. And she's going to talk a bit about the intersection of EMS services and behavioral health, what it looks like now and what our opportunities are. I know we've spent a fair amount of time talking about law enforcement, justice system, and emergency department. And believe me, those other first responders of EMS are actively involved in engaging individuals in behavioral health crisis now. And I believe we'll lean into a little bit of the challenges they have in partnering in the crisis system based on reimbursement and other things, and what we might be able to do to improve that partnership going forward. So look forward to that discussion in just a little bit. Karen, can we jump in and see Margie's meme for the day? Look, every week Margie's come through, and we were hopeful Margie be able to present, but Margie is here at the CIT International Conference receiving an award this morning. In fact, several of our members of our regular call are here right now, and they're participating in that. Vic Armstrong was doing the keynote presentation yesterday. Our own Tanja Miles is presenting right now and getting that award to Margie Balfour. So fantastic event. And this one, I love this. I think it's Margie's most optimistic, right? She feels like we're 11 months away. We're going to get there. I don't know if we're going to get there in 11 months, John, but we're going to get there. And she says someday in our future could be us in a couple of decades, might be our children, Preston, that are following in our footsteps, or Ruchi. And they're going to say, we used to call the police when we needed mental health care. And our grandchildren are going to say, sure, Grandma, let's get you to bed. Because that makes no sense. What do you mean we called police when we were in a mental health crisis? That is exactly what we currently do. And of course, the transformative work all of you are engaged with to make a difference matters a lot. And so, being at this conference is interesting timing for me. And maybe that's why Margie came up with this meme this week. She is here. We are around 1,000 law enforcement leaders from around the country, CIT representatives, as well as behavioral health leaders, all figuring out how do we do this better together. And, Sabrina Taylor's been leading the local efforts as the vice president for CIT International, and it's in her hometown here, Phoenix. Ron Bruno is here. And Sam Cochran gave me something to think about yesterday when we sat down for a few minutes. And Sam Cochran is the founder of CIT in Memphis, Tennessee, and done amazing work through the years. And Sam says, look, if we don't put this right, meaning not only answer the calls, but send someone out, those mobile responses when and where they need them, or we don't have a facility to take them to that's going to say yes each time when they're in a crisis, we're going to hit what he described as a brick wall. And that brick wall means for us, we have to turn to law enforcement again and ask them to jump in and do the work that's happened for 54 years as 911 has operated, which is a law enforcement justice system response, which we all know we want to avoid. But the timing is challenging. It is all in front of us. And there was one other quote I heard from a NAMI, I believe it's a NAMI, Ohio affiliate that came to me and said, her favorite Sam Cochran quote, which I think applies here, is look, how many, can't raise hands, there's no way to do that on this as they're Karen, but how many of you know Fred Astaire and Ginger Rogers? I'm old enough to know that. Pretty impressive dancing. I see one. Mary Jean raises her hand. Tammy, yes, we know who that is. All right. So if we know who that is, and they're doing that, look, Fred Astaire, what we would say is, what a marvelous leading this incredible dance. Many of you are leading this incredible dance to figure out how we change the way care is delivered for people in acute mental health and substance use crisis. But he follows up, and I want to think about this with our law enforcement partners or others. And he says, don't forget about Ginger Rogers. She had to do it backwards and in heels. And as we bring people with us, let's keep that in mind. Our partners are trying to do this together. And this is a collaboration. And again, it's been a remarkable reminder. And I haven't found one of these 1,000 law enforcement leaders around the country that have said, yeah, we want to keep hold of this mental health crisis response ourselves. They want to find a way that we are able to jump in and do that work. And it's really a remarkable amount of support we've seen throughout. So I am hopeful that Margie continues with these optimistic memes. And I do believe it's true that in future generations, they won't be able to understand why in the world police were ever involved and might not believe it. But right now, that is our first response, and that is the way we're doing things. So can we go to the next slide, please, Karen? Look at this. So this is our participation and our record high for this group. Oh, I just stole something from Andrew. Sorry about that. Our record high happened in June. And we keep pushing up our participation. And this actually identifies 600 people on our email distribution list. 600 is a pretty significant number, but I actually think we're over 670 as of this week. So we continue to grow significantly. Our participation in the weekly calls is growing. And as we just said, we are 11 months away from really trying to be in a position to implement. And we have a remarkable group of participants. If somehow your national organization isn't listed among these 54 here, please put that in the chat so Karen can add them into this mix. The other thing we want to do is recognize our states. And right now, state Medicaid, we've got 10 Medicaid leaders that we believe have joined the call so far. And look, this pays off. Let me just shout out to a couple of these in blue. Because they are also ones we heard leveraging this HCBS opportunity, right? In Indiana, it meant over $900 million being available for more behavioral health services. In Arizona, $400 million for this. So those of you that don't have your Medicaid partners in yet, let me say this universally, when I meet with states, Don, it's how are we going to fund this so it's sustainable? They appreciate the startup funding. They appreciate those things. But look, sustainability, especially in you with Medicaid expansion in your states, is going to require and benefit from those individuals that are Medicaid at the table, understand how to do this funding, and you're going to leverage your federal match because a majority of people we serve are newly eligible individuals in crisis, where 90% of that bill is actually going to be covered by the federal match. So really important to this work. And I know something we'll be leaning into more and more with Tom Betlock later in the calculator piece. All right, Karen, can we jump into the next one? All right, so those of you that haven't gone online, if you start at crisisnow.com, that's where I start all my searches. That's the National Association of State Mental Health Program Directors website. A lot of fantastic resources there. There is a crisis talk tab in there, and there are ways that we can get to our 988 crisis learning community weekly calls. And so each one of these is recorded. You can go back and look at them. And if you click on the 3 dots near there, you can get a transcript of the information. You can get the chat in there, and we do enter links into the chat. We enter a fair number of other vital pieces of information. So you can always go back and reference those. And if you've missed sessions, if you're new to the call and you want to check, they're all available for you, as well as key PowerPoints and other resources that we've used throughout. Karen, can we go to the next slide, please? So this is where we want you to try and join our learning community in a real formal way. This is one in which we're all sharing information. The design of this is that we learn from others that have gone before us. Some of the successes we've had, some of the challenges they've had, and then we have the subject matter experts jump in, including John Draper and his team at Vibrant Emotional Health that are helping us to figure out how we can make 988 a true success going forward. And whether that's a true success in the next few months, the next few years, this is about creating a sustainable model where we can move forward together. So we're very excited about that. What would I would encourage you to do is reach out to Karen if you want to get on that distribution list. Again, hopefully, Karen, you can put your email address in the chat so those that want to reach you directly can get subscribed. They can get all of the updates that happen. When we have any adjustments or we send out PowerPoints or other tools to you, you'll be the first to get them and share them. And there's a lot of valuable information we've been going through week after week. All right, next one. All right, it looks like it is time to see what Stephanie Hepburn has been up to. Stephanie, every single week you seem to come through with another strong article, which is really pushing the needle on what we do next for advancing crisis care. And this time you've truly gone international with this work. And so love to hear what you've been working on and some of the work that's been done post-COVID in the UK.
Well, thanks, Paul. Actually, this week, Sue Murray was the one who did the interview and the article, and it's phenomenal. She wrote, it was great. She wrote an excellent piece on how the COVID pandemic pushed the UK to expand its 111 mental health reach. Today, we have Catherine Sage. She was one of the interviewees from Oxford Health NHS to chat about the article. And she's the head of service of mental health urgent care. And in the article, she shares how they quickly set up a dedicated helpline that was actually in direct response to people in distress from the pandemic. And then they moved the line over to NHS 111. If Catherine's on the line, it would be great to get her to share a little bit about the benefits of moving over to 111, how it's helped foster parity, and how they're using the repeat caller data to better match people to care. Catherine, are you on?
I am. Yep. Can you hear me?
Oh,
okay?
Great. Yes. Thank you so much
everybody.
for jumping on the call.
That's okay. And it's really brilliant to be here with you. And we're really grateful for your kind of interest and enthusiasm around what we've been doing in Oxfordshire and Buckinghamshire. So hopefully people have had a chance to have a look at the article, and huge thanks to Sue Murray for the work that she's done on it. So as you've already said, we were kind of put in a position at the beginning of COVID of needing to accelerate a plan that we had for a couple of years' time to have a 24/7 mental health helpline for Oxfordshire and Buckinghamshire. We set that up very rapidly over a period of a couple of weeks. It was a really intensive period of time for us, as I'm sure it has been for everybody. But working really closely with colleagues across the organisation to kind of get that set up. And as you've already kind of alluded to, we ran with that for a few months before then transitioning the service into 111, which is a sort of much better platform to be operating the service. So 111 was already a very established call line in the UK, mostly utilised for physical health conditions. We had mental health clinicians embedded with 111 for a number of years, but in a very kind of small scale kind of way. So when we transitioned the helpline into 111, we now have mental health clinicians who are very experienced working in 111 24 hours a day. So 111 is a kind of very commonly known number in the UK, and gives people a very sort of immediate way of being able to access mental health care very directly. So people call 111, they get triaged in the normal way. So we would kind of rule out and exclude any kind of mental health, any physical health issues that the person might be presenting with that need immediate attention. But as soon as that's done, the caller can be passed through to a mental health clinician who will assess their needs and work out with them which part of our services they should go on to access. And as a key part of that, anybody that's presenting with suicidal ideation or risk will have a safety plan that's formed with them and shared with them after the call, and a plan for how they're going to get further help from mental health services. So that in a nutshell is kind of what we've been doing. But yeah, I think some of the other benefits of the 111 platform are just around the sort of technological basis of it. It's also allowed us to do a lot of work around onward pathways from 111, so working out kind of where people go next and what type of healthcare they go on to seek. Helps us to be a bit more sort of savvy around how we're sort of planning the onward pathways from 111. So there's been a lot of kind of learning from being able to use that platform.
And you've been able to track repeat callers, is that right?
Yeah, so we've had quite a sort of well-established frequent caller program in Oxfordshire over the past few years, which we've always kind of used data to inform who we might want to be interested in and in contact with, specifically around their kind of frequent calling or use of urgent and emergency services, but definitely within 111. Yeah, they, as I say, the kind of technology allows us to have that information in real time and be responding to people much more sort of rapidly around that kind of frequent calling behaviour, and having good bespoke plans in place for each person that might be utilising healthcare in that way.
It was interesting because of the program and putting it on the 111 platform. I read that only 1% of calls to 111 are now being referred for immediate emergency mental health service. That's astonishing.
Yeah, I mean, I don't think actually our activity and outcomes are much different from some other similar helplines in the UK, where we would see a sort of 80-20 split between sort of mild to moderate presentations and urgent and emergency. Even within that sort of 20%, we're able to kind of work with people to get them in contact with other parts of our urgent mental health care services. So not needing a kind of within 4-hour response. That would be how we would define an emergency. So I don't know if that's the sort of same parameters as you might be working with. But yeah, for us, an emergency is a response that's required within 4 hours.
Yeah, that's really remarkable, right? I think these are fundamental shifts in how you can connect people to care at different levels as well, right? We have focused a lot on our crisis response, but connecting to outpatient services, as you said, that can be done in less than 4 hours are also key. And some of the things we see in our crisis lines for response resolution. I've actually, again, being here in the conference, I've had others say their resolution on crisis calls is roughly 50% without sending someone. So it sounds like you're expanding those resources for that sort of success.
Yes.
Fantastic work. Thank you so much. Appreciate it. Karen, can we jump into the next slide, please? All right, it is time for our SAMHSA update. I don't know if Anita Everett has been able to join us.
Paul, Anita is not here. This is John Palmieri, so I'm just going to go ahead and provide the update and then pass it on to Richard for his updates as well, if that's okay.
That's fantastic.
So a couple of things that I wanted to report out on from SAMHSA, happily reporting that we are expanding our team, really in recognition of the tremendous amount of work and the tremendous opportunity that is presented to us with respect to crisis system transformation. There are a couple of people on the call now who I just wanted to introduce to this group as new members of the SAMHSA 988 crisis team. So Kate Galatas is here, who's our communications lead and who's on loan from CDC with a lot of experience with public awareness campaigns and messaging. And so I'll have her in a minute just introduce herself. And then Becky Zornek is here as well, and she is providing a lot of support to the team with respect to project management and our work plan implementation, and really making sure that we are tracking all of the important tasks that are needed for successful implementation. So Kate and Becky, can you just go ahead and say hello to the group?
Hi, everyone. This is Kate. Happy to be here, happy to be a part of this effort. As John mentioned, I'm on loan to SAMHSA from CDC, where I've been the Deputy Communications Director for the agency for about 10 years, and have had just a lot of experience with national campaigns and have done many important ones, but honestly can't think of one as important as this will be moving forward for the country. So I'm very grateful for this opportunity to be a part of this and look forward to working with all of you.
Hi, I'm Becky Zornick. I come from ACF. I was there for 2 years, and before that, I was at SAMHSA for about 8 years. So I'm excited to be back at SAMHSA and to get to be a part of this exciting work.
Thanks, Kate and Becky. And Paul, before I just hand off to Richard, I just wanted to provide a follow-up. I know that there had been a couple of requests for Thiessen Thomas, who oversees our mental health block grant program, to come and provide a report. And he is not available today, but we'll do that next week if that is okay with you.
That would be incredible. I think that is one many of the states are asking about right now. And again, how can we utilize that funding best? And I think even last week there was some leaning into, do we have an update or any progress on potentially moving that mental health block grant set aside from 5% to 10% for crisis care?
Yeah, so he'll definitely be here next week to provide an update on all the work that they're doing with respect to the set aside and data collection. And then I'll just pass it off to Richard for his updates.
Thanks, John. So I'll just mention a couple of things. But actually, if I might start off with a question. Thanks for the update from England. We're very familiar with the 111 system in England. Well, I shouldn't say very familiar, but at least somewhat familiar, because they graciously hosted SAMHSA, the FCC, and VA, as well as Vibrant. And we spent 3 days studying the 111 system in London, and it is an extremely impressive, system moving forward. I did have a question, which was the 1%, if I heard correctly, the 1% number for having to engage police or emergency rescue. I was wondering, was that 1% of mental health contacts? Because one of the things about the 111 system was its broad scope around all kinds of health issues. So whether it was 1% of mental health calls or 1% of all calls would make a difference. So could I check on that?
Yeah, so it's 1% of all mental health calls, and so not everything that's coming into 111.
Very good, thank you.
Yeah.
Thank you so much again, and again, thanks for the incredible hospitality that was afforded to SAMHSA, the FCC, and the VA, and our visit, which was the summer before COVID. So I'll just mention a couple of other things. SAMHSA has weighed in with the FCC on texting to 988. We weighed in support of texting to 988. And that, is filed along with the, all the other filings around texting. This was a letter from our Assistant Secretary to the acting chairwoman of the FCC, but it is now publicly available. Also, yesterday we had the second meeting of the U.S. Department of Health and Human Services Behavioral Health Coordinating Committee Subcommittee on Suicide Prevention and Crisis Care, and we will be launching the working group on 988 and crisis care over the next several weeks before our next meeting of that committee. And this group will have representation, and I said it's really quite impressive. It will include the Administration for Community Living, the HHS Office of Civil Rights, the Assistant Secretary for Financial Resources Office, the Assistant Secretary for Performance Evaluation Office, the Center for Medicare and Medicaid Services, the Indian Health Service, the Assistant Secretary for Preparedness, as well, of course, as SAMHSA and potentially others. So overall, it's one of the most robust and best coordinated HHS efforts for suicide prevention at least that I've seen in my career. So we're very excited about it moving forward. So that's what I have.
Great updates. Richard, one other question I have, and it relates probably to Kate's role a little bit, is we are seeing varying levels of readiness for 988 as we are aware. 8 states passing legislation and moving forward, and some funded, and we have these opportunities, others not. Are we going to be evaluating not only a national strategy around communication, but supporting state strategies where they may be at different levels of implementation, or what is the thinking around communication for those states?
Well, obviously that's a key issue that you're raising, which is variation in performance. And, some of that, you can see by who's passed a law, but who is not. But then, there are differing levels already of state support for their crisis services, irrespective of whether they've passed a law. So it is, certainly something that we're looking at in a number of different areas. We're looking at it from from the perspective of capacity and we're looking at it from the perspective of what is the needed data streams that we'll be needing to monitor that we may not have today. Right, we do get lots of data from the Lifeline, from Vibrant. I review the data, the national data every day. But you said that conceals a lot of variation. And so what we can both get through the telephony system, but also through other sources, that's through the block grant, otherwise through the Lifeline grant, or through any kind of new requirements. These are things we're all looking very closely at, because I think that, the point that you're making is that as 988 gets, and correct me if I'm wrong, as 988 gets implemented, there's a critical need to be able to monitor how the success of its implementation. And that includes a number of different areas: answer rates, call abandonment rates in the telephony system, but also things like the number of emergency rescues that are sent. How often are the police need to be engaged? What proportion of callers are at imminent risk? We have a data stream currently from Vibrant on suicide attempts in progress. And the suicide attempts in progress will be critical for the back and forth between the Lifeline, between 988 and 911, because we think that there are lots of calls going to 911 that could go to 988, but some of these that are suicide attempts in progress will need to rapidly coordinate with 911. So, and having a sense of the dimensions of that is one important data stream that would be needing to be monitored. So we are absolutely thinking about these issues. John, is there anything else you wanted to add about that?
Yeah, thanks, Richard. I mean, I would really just echo to a large degree what you said. I would say that the activities, the variation in readiness with respect to state implementation of 988 is a key consideration. On a number of fronts. We're in the process of doing work, assessing what the state readiness and what their needs are, certainly through the block grant, through Vibrant, through convenings that are planned in the coming months to really get a better sense of what that variation in readiness is, and really trying to provide some guidance around resources, and then also linking that to our communication strategy and framework so that we're really messaging clearly to different audiences depending upon where they are in the implementation process, and really having more nuanced messaging approaches, understanding that there's going to need to be variation in how the messaging is linked at the local and state level.
And John, if I could just add two quick things to what you and Richard shared. I think a number of you have heard us talk about and present some of the high-level aspects of the SAMHSA internal work plan on 988 in the past. And I think there are two aspects here that are relevant. One is we believe going forward, especially as we get into the fall, there will need to be some consistent standard operational playbooks at both the state and crisis level. And so I think those are things that we are actively thinking about. And second, there will need to obviously be technical assistance that varies state by state. And so I think that is another component as we look to the fall and winter that are actively on the radar to build on and supplement some of what Vibrant has already done through the state planning grants. And I just also want to address some of the comments in the chat real quick. I think, Mary, we can certainly schedule a call at some point in the future going forward, perhaps on one of these Wednesday conversations where we get into some of the details around the 988 public awareness campaign. That way, everyone who's doing amazing and extraordinary work in the field can help amplify some of what we're thinking about. And so I think that is certainly on the radar and something that Kate will be helping us lead and drive.
As you talked about that playbook, just one follow-up, Ritan, and Richard, your statement was support for text in chat. Is that going to be an expectation that will be available with 988 implementation then?
Well, as far, so the process for FCC is that, they have issued their notice of further rulemaking on 988 regarding texting. So they're going through that process. I think certainly our expectation is, given some of the public statements by the acting chairwoman of the FCC, is that texting to 988 will likely be ordered. That's certain, but this is the FCC is an independent regulatory agency. They have a process that they go through, so they are collecting that information, looking at it. And, then the next step for them would be to issue an order. But until they do that, we don't know for sure whether there would be texting to 988. And we don't know the timing for that. Would it be the same as for the phones? Would it be the same July 2022 implementation date? And that was one of the things that they asked for input on. So, given the fact that we don't have that there won't be anything finalized yet for some period of time, I think we're working on the operational assumption that there will be texting to 988. And again, one of the reasons that we are in support of that is that we know that people were texting to the existing 10-digit 1-800-273-TALK number, even though there was never a shred of promotion or encouragement to do so. People were doing it anyway. So people are clearly going to text to 988. The only question is whether there'll be somebody on the other side to respond. So that was part of the rationale for SAMHSA, which we were explicit about in our letter to the FCC chairwoman.
Terrific. Hey, thanks, Richard. Thanks, Paul. Apologize for joining late. I'm in South Dakota today, but let's shift to an update from Nashville. I understand Brian has a little bit of an unstable line. Megan, are you giving us the update today?
Yes, and I have a stable line, so we're all good. Okay. So anyway, no, but thank you, David and Paul, and thank you, SAMHSA, and thank you to all on the phone and the healthcare workers who are working so hard to defeat COVID-19. The states continue to focus on vaccination and mitigating against COVID-19. The leadership is exhausted, but continues to work relentlessly. In addition, they are working to develop post-COVID strategic plans. We keep pushing that post-COVID strategic plans because we want to keep that kind of long-term view. But states report being overwhelmed, but optimistic. So they are integrating an equity focus into those strategic plans. So we're really excited about that. They are using the supplemental funds from the COVID relief plans to move ahead with first episode psychosis, 988, and crisis services. They are using the SAMHSA national guidelines for behavioral health crisis care to move their crisis services forward. So we're excited for all of those efforts. At Nashville, we are finalizing our 2021 Beyond Bed papers and the plans for our annual meeting, which will be virtual in September. I will say that the 988 Learning Community Jam will be part of that annual meeting and connected on Wednesday, September 15th. So we're really excited for the next steps to make that happen. And again, thank you for the united effort to make this transition to 988 a success. Thanks.
Terrific, Megan. And Paul and I will be meeting with Megan and Brian and others to talk about that special edition, looking to our SAMHSA partners. So if you have ideas for a special edition Crisis Jam, we'd love to hear them. Karen, let's move ahead, and we're going to skip both the normal Sarah and state updates so that we have time for our featured presentation. So Sarah Corcoran and Natalie, we'll come back to you guys this coming week. And also, I know that Kim Myers and some of the team in Utah did some special effort for our second edition state card. If you're collecting your baseball cards at home, you've already seen Washington State, and we're going to do Utah next week. So Karen, Kim, it gives us a chance to come back to this. But I want to make sure we have time. John Draper and I had a terrific conversation with Dia Gainor from the National Association of State EMS Offices. And the dialogue that we had both with Dia and her partner with some of the first responder and behavioral health engagement opportunities was really terrific. Dia, are you with us to tell us a little bit about what states are doing with EMS and begin to lean into this conversation of behavioral health and 988 and crisis care?
Absolutely, I am, and hopefully my audio is functional.
It sounds great. We see you, and you've got your logo up. How cool is that? Welcome.
Absolutely. Well, thank you. Thank you very much. Mr. Covington, I couldn't thank you enough for the opportunity to just share some insights from the world of ambulances. I'm the executive director of the National Association of State Emergency Medical Services Officials. Our acronym is pronounced NASEMSO. Our members are the state agencies that license paramedics and EMTs. They license ambulance services and other EMS agencies that respond to 911 calls. Most of them are based in the state health department. And most importantly, and this is where it's going to sound, I think, in parallel to the interests in mental health and substance use disorders, is that they have historically been responsible, at least since the early 1970s, for engineering systems of care for time-sensitive emergencies. And I'll just start by, sharing I think a good analog, which is state trauma system. And those have been built since the early 1970s to address a specific set of conditions among all the patients that ambulance services respond to, where triage tools are built for use by all EMS personnel, where guidelines for clinical care of how those patients should be evaluated and treated are built for those patients. Most importantly, transport decisions, how individuals should be transported, and finally, destination determination. Which is the best right facility, the closest appropriate facility for those patients. And so in this space of response to mental health and substance use disorders and the work that's now erupting in this space, couldn't excite us more, because our members have both the regulatory and the systems engineering opportunities to change how EMS, ambulance services, and other EMS agencies change the way they care for patients in this space.
So Dia, these decisions of where to take someone are not gut reactions or clinical judgment, they're protocolized. Talk just a little bit about that. And one of the key elements you mentioned to John and I was the influence of third-party liability in that conversation.
Yes, well, at least third-party insurers, let's start there.
Yeah.
Historically, the Centers for Medicare and Medicaid Services regarded ambulance service as just that, a transportation service, with a default expectation and condition for reimbursement that the destination be an emergency department, period. Therefore, EMS agencies, as our young systems that were built, again, beginning only in the 1970s, prior to that, most ambulance services in the US were operated by funeral homes, The default design of EMS systems was, well, we take everybody to an emergency department.
Right.
And beginning back in the early 1990s, this thought about, mobile integrated health began to emerge where, wait a minute, the emergency department may be not only the improper place to take someone, say an individual with a minor condition that could wait till the next day in a clinic, say, a minor burn to their forearm, that instead there might be alternative destinations that are appropriate. That creates a big financial dilemma, but EMS agencies have been rising to the cause of saying, we have other destinations that are very appropriate. And we're thankful that CMS has started a pilot project whereby individuals can be transported to alternative destinations and still be reimbursed for that patient transport.
So, Dia, one of the conversations we had, I think I referenced the idea of the hospital being a choke point when everyone has to go through for medical clearance before even being considered for referral into some kind of level of care. You called it a dead end for many individuals in crisis. Can you say a little bit more about what you meant by that?
Sure. Well, I'll start first with, besides being a lifelong bureaucrat and a survivor, I was the state EMS director in Idaho for 19 years and worked for the state of Maryland's EMS office prior to that. But I was also a paramedic in the field, a volunteer paramedic for 12 years. And the dead end is this. There's a presumption that emergency departments have, several things in place. One, bed availability. Two, staff availability and capability. Three, clinical capabilities that match the individual's needs. And ultimately, the disposition capability. And that's really, those are a bunch of assumptions about an emergency department that are being made when that's the default destination with no consideration for any other options. Instead, and what we're seeing so vividly now during the pandemic is if there's not a bed available in the emergency department, if there aren't staff with the capability to appropriately evaluate the patient, and if there is not the disposition opportunity, whether that's the transport option or the mechanisms in place to get that patient to an alternate facility, that's a lot of work inside an emergency department that many aren't geared to do. And worst of all, the triage that's happening now, and as goes Texas and California, so goes the nation, ambulances with, quote, non-critical patients sitting in the parking lot of hospitals for hours. Just this week, Texas is reporting ambulances that are staged with the patient in the back of the ambulance for 3, 4, and 5 hours before being even granted access into the emergency department. When that's an individual with a substance use disorder or a mental health crisis who are being sort of relegated to, they can wait because the paramedic can take care of them. What's wrong with this picture? Even if we take COVID out of the picture, it's still a very inappropriate scenario.
Wow, Dia, that's incredible and so disappointing for where we're at, but it really lays the groundwork for the burning platform to make these changes. Another area you and I talked about with John Draper and with your partner was the issue of we're certainly talking about standardized clinical guidelines and practices in behavioral health, but it's much less, I think, developed and nuanced than what you called, I think you called them the culture of standing orders within EMS and first responders. Can you talk a little bit about what we might gain from you there?
Well, absolutely. First of all, let's use, a heart attack. A heart attack is a heart attack, whether you're in Anchorage, Alaska, or Atlanta, Georgia, right? And the clinical needs of the patient are not going to vary, save maybe whether it's raining or, sub-zero temperatures outside. Those clinical standardizations, whether they're called protocols or guidelines, states may use different terminology, are something we've worked on for decades. We're on version 3. We're about actually to publish version 3 of the National Model EMS Clinical Guidelines that are specific to pre-hospital care providers for EMTs and paramedics. Those guidelines are, 400 pages long because they address every possible emergency type, to include behavioral emergencies, suspected drug or medication overdoses, et cetera, and outline procedurally the steps that the EMT or paramedic should follow, to include not only the triage and treatment parts, but the destination determination, and in the cases of conditions like trauma and others, use of helicopters. So we've long been in the business, and this is a NASEMSO publication, thanks to funding from the NHTSA Office of Emergency Medical Services and HRSA's EMS for Children program, to help the thousands of EMS agencies and 1 million EMS personnel approach patients appropriately and make good clinical evidence-informed or evidence-based decisions about how to treat and transport those patients. So the opportunity for change is significant because that leverage of standing orders, protocols, clinical guidelines, whichever the terminology is in your state of interest or on a national level, exists because we publish those for use by local EMS agencies.
Dia, if you could share with me that third version that's being published now, I'd love to share that with this group. SAMHSA has released its first version of the National Guidelines for Behavioral Health Crisis Care, but I'm not sure we all, those of us who were all involved in that, consulted with the document that you're talking about, and would love to see both the format and structure as well as how you tackled some of those behavioral health issues. You've already raised this issue of destination determination. That's been great, but the other conversation you had with John and I was the idea of the alternatives, especially during COVID, and what you called online medical direction. Talk a little bit about that.
Oh, I'd love to. I know many regard the term telehealth as something sort of new and completely different. Any of you on this call who are old enough to remember the show Emergency, I know at the very beginning we were talking about bands, so I'll bring up Genesis and Pink Floyd for myself. But any of you who remember Johnny and Roy, the famous Los Angeles paramedics who were profiled on that popular TV series Emergency back in the 70s, who were caring for a patient out in the field, on the side of a road, or in their living room, would get on the radio and call Rampart General while they were still in the patient's living room to talk to the physician at the hospital to discuss their findings, the patient's vital signs, what they found, what they know, their evaluation of the patient, and the physician would give them instructions on what interventions to start, what interventions to stop, and better still, transmit information like an EKG. We were doing this back in the 70s. And so there's a very strong sense of comfort throughout the EMS industry in the United States, because our state EMS offices, as regulation of ambulance services emerged in the early 70s, basically uniformly across the country said, if you want to be an ambulance service and be licensed as an ambulance service in the United States, you will have these communications capabilities. We didn't call it telehealth, but in effect, that's what it is. Right. So that capability is also resident uniformly throughout EMS already.
Terrific. Wow. Dia, the last thing I want to, and then I want to open it up to some comments or questions. Paul, Richard, John, others that might want to jump in. But you referenced 1 million EMT and first responder staff out there. So that workforce has been, you've been building that over the decades. We're certainly thinking, how do we build up this workforce related to mobile teams and facility services, and thinking through workforce shortage and the pressures and strains of this. Can you talk about recruitment, retention, and how that, some of those challenges within the EMS first responder workforce?
Yes, I will briefly, and this in and of itself could be its own, sort of presentation or follow-on conversation. Great. So since NASEMSO members license EMTs, paramedics, and the levels in between in every state, the District of Columbia, and 5 territories, we can count absolutely the number of personnel who are licensed to function in that out-of-hospital, pre-hospital capacity in the United States. And we completed the last count about a year and 3 months ago, and it was just over 1 million EMS personnel. Now, though we do not use the term first responder because those EMS personnel may or may not be fire department based. They may or may not be hospital based. They may be a volunteer who receives no compensation whatsoever, but who rises to the same educational and licensure standard. And so those personnel are very diverse, and the systems in every state are very, very different mosaics of organization types. And there are, at the same time we ask states of their count of licensed EMS personnel, we also ask states for how many ambulance services are licensed. And that's about 14,500 ambulance services in the United States. That's a big footprint of availability of resources. And I know there seems to be, at least in my experience so far, this tendency to talk about police, but there's often an ambulance right behind that police car. And so we're anxious to find the ways in which the system engineers in us, can help with how those EMS agencies either improve on their existing promising practices or implement new practices that are going to benefit patients and improve patient outcome. We're ready.
Wow, that's terrific. And it just helps me also with the language. I think I've been too casual with first responder. So in the professional world, EMS is distinct from first responder being fire and police for those public safety emergencies.
Absolutely. Quickly, depending on where you are in the country, and even if you're from a national or federal organization, if you're in Maryland, you look around and every ambulance is fire department based. But if you're in New Jersey, every paramedic level ambulance is hospital based. If you're in South Dakota, the majority of ambulance services are rural volunteer associations. So referring to a discipline as EMS, it doesn't make sense because of the diversity of organization types that provide ambulance services throughout the US.
Wow, Dia, we've got a host of questions coming through the chat, and we're not going to be able to get to all of them. So I would love to have you come back at some point in the future. But let's get a few comments, questions. Let's start with Dr. Richard McKeon. Any reflections, Richard, or questions for Dia?
Thank you so much, David, for having arranged this, and Dia, thank you so much for your presentation. I think that your organization is going to be a very important partner for us as we move forward. Along with others such as the National Association of State 911 administrators and NENA, et cetera, operating in this space. I did just have one additional comment, but I would note that under the Mental Health Block Grant, one of the 4 approved areas for the crisis set aside, in addition to the hotline mobile crisis and the crisis receiving and stabilization facilities, there's also language there around protocols for people at higher risk for suicide. And I think that means that states can utilize some of that funding for the development of the kind of protocols that are going to be needed. And part of, I think, what we're hearing is just how protocol driven the 911 response is, and how we'll be needing to do more of that for 988, including the coordination with 911.
It's critical. Variation is evil.
Variation is evil. So this artisan sort of approach, so great for some foods sometime, Dia. We've had too much of that in the behavioral health, and this is a terrific opportunity for us to learn from what you guys have done and are doing. So Paul, you went in the text exactly where my brain was going as Dia was referencing system design over and over again. John Franklin Sierra, you knew this was coming. Reflections, comments, questions for Dia. Dia, John Franklin Sierra is part of Dr. John Sharon's team with LA County, and gave a two prior presentations to this group on system design, well, which is his professional background. John, what are your thoughts?
Just, yeah, that this is, I mean, just such a critical thing that we need to figure out. And we've gotten the same feedback from our fire EMS colleagues and even law enforcement colleagues in LA County that, the fluidity of emergencies and the kind of the need for, being able to assess and rapidly triage different kinds of responses in the moment kind of necessitates looking at this as an emergency health system, right? Emergency health services. And so in that vein, how do we better coordinate between the medical and the behavioral side of that equation, right? I think that's a really critical thing that we need to figure out. And to add to that, we talk all the time about workforce shortages on our side. I saw the comment, does EMS agency experience workforce shortages as well? And I'm sure they do, but 1 million EMTs, that sounds like a lot more than the number of mobile crisis providers we've got around the country right now. And what can we do in the short term to better leverage the existing EMT workforce toward the needs of those folks experiencing behavioral health crises as we work toward a system, that's more in parity with the emergency medical services side of things? That's one of the questions I've definitely had.
That's terrific. Dia, any comment or reflection?
Well, two components to that question, right? One, the workforce, and are we short on people anywhere? There certainly are places where especially volunteer reliant organizations are suffering, and COVID has not helped in that regard to have an adequate number of personnel to cover the square mileage in rural areas that's necessary, and yet the critical population needs that exist there, right? On the second part of your question, though, but what if we need to do something new and different? That is something that state EMS offices do continually for EMTs and paramedics in what we call setting their scope of practice. And it is a regular, we don't like to lead with our regulatory foot, but in reality, that's how it happens, is that a new skill or device or medical intervention or expectation is introduced to an EMS system by raising the bar on, we now have this educational module that everyone has to take before they renew their license as an EMT or paramedic, or this new skill, as began with naloxone administration before it was it could be provided below the paramedic level. States chose to introduce that skill and say, no, everybody's going to do this, and use that regulatory arm to make it happen. Does it happen overnight? No, most certainly not in states that have 10,000 EMTs and paramedics, but we do it right. Our members do it regularly as medicine evolves and evidence drives the need to change.
Oh, wow, Dia. So Dia, we're used to our partners with the states having the hardest to pronounce acronym. You've supplanted them, but I'd love to hear a comment from the NASBD folks, the National Association of State Mental Health Program Directors. Megan or Brian, any thoughts or reflections? Megan, are you still with us?
Yes. It's just really, really good work. I know that we are very short on time, and we're really excited that we're moving forward.
Terrific. Dia, thank you so much for joining us, and we do hope that you'll be a regular participant, and let's schedule that follow-up time to talk a little bit more about maybe getting into that third version of the protocol, the guidelines, as well as talking a bit more about workforce issues. Just terrific. Thank you.
Thank you.
John Palmieri, Richard McKeon, would love to hear just some final reflections. And there has been a lot of discussion in the text chat around the SAMHSA recommendation to the FCC around chat and text. And maybe we do more of a featured presentation on that somewhere down the line. But obviously, Richard, the way this is working is to leverage the Lifeline network, and there already is chat capability in that network that is emerging. Any additional comments, either Richard or John, to sort of end this section today?
Well, I would just add that, at the moment, what we see is a lot more efforts to access chat. So chat is an immediate priority for us in terms of strengthening capacity. Text, particularly if texting to 988 is approved, will obviously emerge as a really significant issue moving forward. So typically, and you see this in the FOA for the Lifeline grant and in other SAMHSA, we're continually talking about the need to build capacity around phones, chat, and text.
John, any final comment?
My comments really be mostly about the workforce elements in the chat here, really recognizing, and we're very well aware that as we think about resources to make 988 successful, that workforce is a huge issue. And we've been having lots of planning and conversations with HRSA and other partners to really think about a number of mechanisms that we can use or leverage to support workforce development in the crisis space. We are completely on board with the fact that this is a huge need currently.
Terrific. I see John Draper's hand up. John, let's, given that we're at time, let's start with your comment, John, next week at the beginning of the call. We'll go straight to you to launch that out. We've got Jess Stolman-Rainey this coming week, and thanks for joining us today. We'll look forward to seeing you next time. Sorry, Karen, we've got Mary Sauers next week with in fact, Megan, are you still on for a moment just to reference who Mary is, and then we'll end for today?
Yeah, Mary Sauers is the Executive Director of the National Association of State Developmental Disability Directors. And so she's going to talk about the special population of IDD in crisis.
So as we talk about people in crisis calling 988, there certainly would be people with mental health, suicide, and substance use crises, but there are also going to be individuals whose primary challenge is IDD and overlap with those others. So this will be a really important conversation. Thanks, Karen, for catching that. Jess will be the following week, and then Megan will have Steve Hammerdinger. And then Karen, remind me, we'll start with John Draper to start this coming week. And then we'll welcome your feedback on this special meeting as part of the SAMHSA annual meeting. Thanks, everyone. Take care.